See me? If so, say me a hi and hello. A very good evening, first of all. Can you guys see me, hear me? Yes. Okay, all fine, good. Okay, so if I'm audible and visible, let's start with today's lecture, the Daskadam of Pathology by NEET for the upcoming NEET exam. See, there's going to be a revision lecture, right? Good evening, Lydia. Okay, great. Good evening, Samantha. So I want you guys to answer two questions. It's going to be more of how to connect the dots in pathology. I'll have a complete one-shot series inside the app before the NEET PG as well for you guys free. Mine will be on 29th of July. By the time, hopefully, you'll be able to revise pathology and sit for the Daskadam. Sorry, sit for the one-shot series at 29th of July. We'll cover the entire thing. Fine. So today's thing, like I said, it's going to be connecting dots. It's the colors. The colors are the main good thing as well as the villain in pathology, right? So we're going to learn what are the colors means, and we're going to see some classical clinical scenarios, how to decode them, come to a diagnosis. And also we'll have few patterns, and also we have few one-liners like investigation of choice, and finally we'll leave with few keywords, right? So that's the orientation of today. So I would appreciate that if you have more interaction, right or wrong, please do comment. Let's go ahead, right? Let's start. Necrosis, live or dead? See, it's going to be very simple questions like this, but these simple question is going to unlock the mysteries of pathology, right? It's undoubtedly a dead tissue, right? So if it's a dead tissue, the nucleus will be present or it will be absent. So undoubtedly, if the dead tissue, nucleus is going to be absent, right? So in a H&E, what is the color of nucleus? Can anyone tell me that? In a H&E, the color of nucleus is undoubtedly your blue, right? So in a necrotic tissue, will you have blue color? You won't have blue color, right? So in other words, a necrotic tissue is going to be only pink in color, right? So the color is going to be only pink. If you feel something is pink in color, only pink in color, I want you to first think of necrosis, right? Perfect, right? Great question. So I'm going to see something completely pink in color in a microscopy like this. I'm going to think of necrosis, right? So when you come to necrosis, we have multiple subtypes of necrosis like liquefactive, coagulative, caseous, fibrinoid, fat, right? One word about each of them. See, these keywords should help you to recollect all the things what you read about necrosis, right? Coagulative, it's simple thing. Every solid organ in fact will have coagulative necrosis. The commonly repeated one, which organ in fact will not have coagulative necrosis? It's a simple question, right? Obviously, brain or a CNS in fact will not have coagulative necrosis. And please do remember, in a coagulative necrosis, you always have a maintained architecture, which means even though it's a dead tissue, you can identify it's a dead tissue, right? So this is one of the key findings for a coagulative necrosis. In other words, we call them as ghost cells being present. So if ghost cells are seen, you call them a coagulative necrosis. If you see ghost cells, it's a coagulative necrosis, right? Perfect, right? So next is about liquefactive necrosis. For a liquefactive necrosis to happen, it should be seen in an abscess cavity. In case of a wet gangrene, you will see liquefactive necrosis. And like you guys said, you CNS infarct, you'll have liquefactive necrosis by default, right? So in addition to this, I'm just going to ask you a simple question. I want you to listen carefully and answer. In a patient with an acute pancreatitis, in pancreas, what type of necrosis you will see? I'm not talking about something random. I'm asking about in pancreas, what's the type of necrosis you will see in patients with acute pancreatitis? Perfect. In acute pancreatitis, in pancreas, you will see your liquefactive necrosis. You won't see fat necrosis because fat necrosis is not seen in pancreas. It is seen in the surrounding parenchyma, the omentum or the peripancreatic fat, right? Now let's come to caseous. If you see caseous necrosis in any question throughout the world, what's the only diagnosis? What's the only diagnosis for any caseous necrosis? Undoubtedly, it has to be the boss, right? Tuberculosis. It has to be TB by default. If TB is not there, we think of histoplasma, coccidioidomycosis. But again, even in immunocompromised state, TB is definitely much more common than any other thing, right? Perfect. Now let's go to the next one, the fibrinoid necrosis. Oid means like. So fibrinoid necrosis is a fibrin-like necrosis. That's what we mean by fibrinoid necrosis, right? So now in case of a fibrinoid necrosis, you will see in every vessel wall. Any pathology in a vessel wall, you see fibrinoid necrosis. That's nothing but your vasculitis. Not just pan, any vasculitis, be it vaginous, be it your Goodpasture syndrome, any vasculitis, you will see fibrinoid necrosis by default. And there's one condition in one heart disease, you will see fibrinoid necrosis. What heart disease is that? That's your rheumatic heart disease, right? Heart is considered to be the biggest vessel. In rheumatic heart disease, in rheumatic heart disease, in the Aschoff body, you do see fibrinoid necrosis in addition to any vasculitis by default, fine? The last but not least is fat necrosis. In any fat-rich organ, you'll have fat necrosis, right? It can be a trauma-induced fat necrosis in a breast parenchyma or a gluteal region. See, trauma doesn't mean always the patient should fall down. Can I say FNAC is also trauma? It is, right. You do FNAC of any breast lesion, there is a possibility of fat necrosis to happen. IM injection in the gluteal region, definitely there's a possibility of fat necrosis to happen. So any trauma can cause fat necrosis in fat-rich organ, and obviously, like we saw in the peripancreatic fat, in case of an acute pancreatitis, you will see fat necrosis, right? Okay, perfect. So now just one thing, just to make sure your concepts are clear. What is the normal color of fat in a microscopy? I want you guys to comment. What's the normal color of fat in microscopy? In a normal light microscopy, in a routine H&E, what's the normal color of fat? As everyone knows, right? It's clear in appearance, right? So when it becomes fat necrosis, what do you think will be the color? Will it be clear, not clear? What will be the color? A normal fat is always clear, and if it becomes necrotic, whatever may be the subtype of necrosis, microscopy of fat necrosis also will be pink in appearance. It will not be clear, it changes to pink in appearance, because every necrotic tissue by default will become pink in appearance. That's the dictum for any necrotic tissue, right? Perfect, right? This is one slide. See, these are keywords. When you revise, I want you to use keywords. Don't go and read everything. With this keyword, you should be able to recollect whatever you know in regards to the thing, right? I'll give the same PPT for you. I won't be giving PDF for the only reason it has lots of custom animation, right? So whenever you get time, the day before the exam, if you're bored, just keep on clicking the next button. It keeps on coming and it'll automatically trigger the important points, fine? Okay, next. So what else can be pink? Protein can be pink, glycogen can be pink, amyloid can be pink, right? All these things can be pink. It's not just necrosis, right? So how do I differentiate them? So if two things are pink in appearance, what comes to your mind? How do you differentiate them? Ghost cells, Samantha. You will see ghost cells, which is the architecture we maintain, called as ghost cells. You need special stain, right? If necrosis is also pink, protein is also pink, I need a special stain, right? So if you see this word, you think of protein or glycogen or amyloid. Which of these three is positive for Congo red? Great, Rahima. Which of these three is positive for Congo red? But my question is different. Congo red? Undoubtedly amyloid, right? Which of these three is positive for, if we have the term PAS positive, diastase sensitive, what is that? Protein, glycogen or an amyloid? Which is PAS positive and diastase sensitive? Diastase is an enzyme which destroys carbohydrates, so it has to be glycogen. Which is PAS positive, diastase resistant? Resistant is protein, right? So here, when you have a question saying PAS positive, diastase resistant, think of a protein. Sensitive, think of glycogen. And amyloid, obviously Congo red, right? And just to complete it, what's the color of birefringence in amyloid in Congo red? It's your apple green birefringence, right? I want to add one more thing for PAS positive, diastase resistant. In addition to any protein deposit, you also think of this disease. We have a disease in intestinal infection called as Whipple's disease, right? It's an infection. Please don't confuse this with Whipple's surgery in pancreas. There's an infection of the GIT, Triforema whippleri. That organism is also PAS positive, diastase resistant, right? Do remember them, right? Okay, perfect. So now we have few basic pointers. Like I said, this entire class is about connecting the dots, right? That's our entire goal. And collagen is also pink in color. What's the stain for collagen? Anyone? You know the stain for collagen, right? Stain for collagen is Mason's trichrome, and collagen will be blue in color in case of Mason's trichrome. There are three colors: red color for muscle, black color for nucleus, and collagen will be blue in color, right? Samantha, Whipple's disease is an infection of the intestine caused by an organism called as Triforema whippleri. Okay, perfect. So these are the differential diagnosis for me if I see pink in color, right? These are data points. These are the dots. We have to connect the dots in order that we can solve a scenario-based question. If you find scenario-based questions difficult, the only thing is I know facts. Everyone here knows facts. I need to connect them, right? Let's connect. Comment on the first diagnosis comes to your mind. Then definitely we look at the thing. So here our goal is very simple. We look at few facts. I want you guys to connect the dots and come to a conclusion, right? What comes to your mind? A 25-year-old altered liver function detected on routine investigation. Liver biopsy shows pink accumulation, which is PAS positive, diastase resistant. What is accumulating? Just we'll start with that. Great, Samantha. What's accumulating? Protein is accumulating, right? I'll give you one more clue here. One more clue in this patient. This patient lung has pan-acinar emphysema. Perfect, Sagarika, right? So I have a protein accumulation and this patient lung has a pan-acinar emphysema. So you think of an alpha 1 antitrypsin deficiency. Fine. So obviously you think of an alpha-1 antitrypsin deficiency. So in a liver biopsy, if you have PS positive diacetyl granules, it's classical alpha-1 antitrypsin deficiency. That's diagnostic. So that's how scenario-based questions start. See, either you have to be very strong in clinical, or either you have to be strong in this point so that you can solve a question. That's the ultimate goal. Please believe me, scenario-based questions are the most easiest because there'll be more clues, right? This is the funda of the entire session. Let's go with the next. 25-year-old altered liver function on routine examination. Liver biopsy shows intracellular pink accumulation, which is salmon pink on Congo red. Your diagnosis. Same history. See, I have not changed anything, though the history might not be exactly same in real life. But for just for namesake, if I change few pointers, my answer entirely changes, right? It's classical amyloidosis, right? Congo red in light microscopy will be salmon pink. Whatever you guys said, apple green birefringence is seen in polarized light, right? That's a classical symptom of amyloidosis. Since we are an amyloid, I'll just ask you few one-liners which I want you guys to answer. Most common type of amyloid. What's the common type of amyloid? Like AL, AA, A beta 2. AL is the most common type of amyloidosis, right? Okay. So in which patients or in patients with chronic hemodialysis, what type of amyloid deposit do you see? Is it AA? Is it AL? In chronic hemodialysis, you see, perfect. You see an A beta 2 microglobulin in case of a chronic hemodialysis, right? At the same time, if you see a patient with an A beta deposit, so what do you think of? A beta deposit, what do you think of? A beta Alzheimer's disease, right? A beta 2 microglobulin is seen in chronic hemodialysis and A beta is seen in Alzheimer's disease, right? One thing, AIAPP, right? It's islet amyloid polypeptide. In which condition do you see islet amyloid polypeptide deposit? It's seen in case of a pancreatic deposit. Can anyone tell me one disease where you see AIAPP deposit? Ideally two. One is perfect. It has to be very specific. Diabetes type 2. Because only in type 2 diabetes, there'll be oversecretion of insulin, more protein gets deposited as amyloid, right? At the same time, I also can see them in insulinoma. See, amyloid ideally is excess production. In type 1, which is insulin deficient, you won't see amyloid deposit. It's seen only in case of type 2 diabetes, right? Okay, perfect. So few pointers regarding that. That should be more than enough for you to crack it, right? Two more questions. Last two questions, then you'll go to the next scenario. Which is the common organ which will be affected with amyloid? Fastest finger first. The common organ which will be affected with amyloid. It is kidney, right? Which organ involvement will cause death in amyloidosis? No, Sangamitra, it's not fat. It's kidney. Kidney will be commonly affected. Fat we'll take as a biopsy condition. That's all, fine. Cardiac amyloidosis is the most common cause of death in amyloidosis. It's heart or the cardiac amyloidosis, right? Perfect, great. Let's go to the next question. What's the diagnosis? Same scenario, like maybe few changes. 5-year-old altered liver function on routine examination, failure to thrive, liver biopsy shows PAs positive, diastase sensitive substances. So what is your diagnosis and what is getting deposited? 2 words, that's all. What do you think is getting deposited? It's glycogen, right? PAs positive, diastase sensitive has to be glycogen. Glycogen in a 5-year-old, you think of a glycogen storage disorder. Can anyone tell me what glycogen storage disorder is common? So that will be obviously the answer. Liver, the commonest glycogen storage disorder, I'm going to think of an 𝐌𝐞𝐿's disease, right? That's definitely the commonest glycogen storage disorder and definitely it presents with failure to thrive and a hepatosplenomegaly, right? Perfect. Antacid is not that common, right? Survey. Okay. 𝐌𝐞𝐿's is the most common glycogen storage disorder and presents in the classical scenario, right? Next. Same thing. What I've done here is I've changed the clinical scenario. It's same PAs positive, diastase sensitive. So by default, it's glycogen. So what I've done here is 5-year-old, the patient has cardiac failure and failure to thrive and liver biopsy shows accumulation. Patient presenting with cardiac failure and a glycogen storage disorder. What's the diagnosis? See, this is how clinical scenarios play. It's same glycogen, you think of an Pompe's disease, right? So the reason why you think clinical scenario is difficult is you already know the facts. When I know the facts, when I change one part of the fact, the entire answer changes, right? So please be very careful. It will not be like exactly same PYQ will be asked. It's PYTs, that's all. Everyone knows that glycogen storage disorder is important. I can create 4-5 different patterns of MCQs with the same facts, right? So please look at the age, look at the clinical history, look what has been positive for, and then come to an answer. Step by step, The same way you see patients in your real life, right? Next, okay, 10-year-old muscle weakness, muscle biopsy shows intracellular pink color, same pH positive, dye sensitive. Can anyone tell which disease will be muscle phosphorylase deficient? The same glycogen, right? One more scenario, that's all. Answer? It's McArdle syndrome, because McArdle syndrome is muscle phosphorylase defect, right? So it changes accordingly, right? So that's how it changes. Same table, I can create multiple questions, same fact. Medicine is very simple. If you know how to connect dots, that's enough, because you have inflammatory disorder, infective disorder, autoimmune disorder, genetics, neoplasia. That's all. Any organ you take from head to foot, nothing beyond this. Know how to connect dots. That's more than enough, right? Next question. 45-year-old patient. Okay. Bone marrow biopsy shows pink fibers in the bone marrow spaces. Mason's trichrome is positive in these pink fibers. What do you think is your diagnosis? I'm going to one more system here, hematology, but with the same basic facts. I'm not change anything, right? What do you think is the diagnosis? Mason's trichrome is positive for which structure? It's positive for collagen, right? So collagen is seen in due to any fibrosis. Perfect, Sunny, right? The answer is it cannot be Gaucher's. Like Gaucher's will not be Mason's trichrome positive, and 45-year-old is not the ideal presentation for Gaucher. Gaucher will present very early in life, right? So take the clinical scenario: elderly person, pancytopenia, bone marrow biopsy showing Mason's trichrome positive, has to be an myelofibrosis. Bone marrow fibrosis, that's myelofibrosis, right? That's as simple as that. This is the only thing which we learned, but we can easily solve a question based out of it. You have completed your internship. You know how to approach a patient. Please don't change anything in that. Have the same approach here. You'll definitely go to the different level, right? Let's go to the next one. 45-year-old fell down while riding a bike. Few days later, microscopic analysis shows tissue pink fibers, which are Mason's trichrome positive. What do you think is the stage of wound healing here? Is it like the day 3, day 4, day 5, day 7? What day do you think? So tell me, what is the inference here? What do you see? What you're seeing in the microscope here? Can I call it a scar tissue? Yes. Scar tissue, where do you see? You see generally in day 7, right? So there are 2 steps in wound healing which can have collagen, right? So please carefully read. If you have a patient with both blood vessels and collagen, think of a granulation tissue. If you see only collagen, think of a scar tissue, because both of these, granulation tissue will also have collagen, scar tissue will also have collagen, right? But scar tissue will not have good amount of vascularity. It's avascular structure, right? Just one more leading question. Lydia, amyloid is positive for congruent, collagen is positive for Mason's trichrome. Okay. One more leading question. Tell me, which type of collagen do you see in patients with granulation tissue? Yes, Carpenter is right. In around 4 to 5 days is what you see granulation tissue. It's type 3 collagen, right? You see type 3 collagen in case of granulation tissue. You'd see type 1 collagen in case of scar tissue, right? That's also one liner. And someone, Adonis Edoni, right? Nimara Edoni said that you will see maximum collagen deposit in 21st day. Perfectly right. And the start of collagen formation starts at 7th day, right? Perfectly right. Great. Amazing. Okay. One more question. Let's see if we can come to a diagnosis. Maybe slightly increasing the notch of this question, or maybe kind of the difficult level. But still, if you're strong with the basics, nothing is difficult. 50-year-old non-productive cough for 4 years with increasing severity. Lung function is reducing. Biopsy shows pink structure, Mason trichrome positive. What's your diagnosis? Samantha, type 3 is seen in case of granulation tissue and type 1 is seen in case of scar tissue. That's all I said. Can anyone come to a right diagnosis? It's a simple, pretty simple one. Great, Sunny, right? It's ILD, interstitial lung disease, right? So in interstitial lung disease, or microscopically I can call it an idiopathic pulmonary fibrosis, that's more than enough, right? So progressive cough, clinically, classically presenting, non-productive cause, progressive onset of lung dysfunction, deteriorating lung function, and microscopy shows fibrosis. It's idiopathic pulmonary fibrosis or an interstitial lung disease, right? Just to complete this entire spectrum, it's very difficult to take a lung biopsy, right? So what do you think is the investigation of choice for ILD? Because for me to take a lung biopsy, which is already getting destroyed and damaged, and the patient's respiratory failure is a bit difficult. So what's the investigation of choice? You go for an HRCT, right? HRCT can easily pick up, because in HRCT, what can anyone tell me? What is the finding of ILD in HRCT? What's the finding? HRCT is a classic right answer. What's the finding of, have you heard something called in ground glass appearance? I think Shubham GGO says for that. Okay, ground glass appearance, right? Honeycombing can also be seen. Ground glass appearance can also be seen, right? So ground glass or honeycomb means one and the same. So what happens is, let's try to correlate a microscopic finding to the radiology, right? Let's assume this is a lung area. Fine. Interstitial lung disease generally is a patchy disease. So let's say wherever I have put round ones, all these places, my lung is still intact. So will it be black in color on a radiological finding? Yes. And wherever I'm shading here is a fibrotic area. That's how the fibrosis will be there in case of an ILD. So all these fibrotic area will be white in color. So when you look at that, it looks like black dots, white area, like an honeycomb or ground glass. I'm sure you must have seen ground glass. Have you seen the glass in an ICU door where it will be neither transparent, not opaque, translucent? Or the bathroom, the ventilators in the side, it will be a cross glass, right? It will have tiny areas of clear visibility and areas of very thick glass. That's why it looks like a ground glass. A ground glass looks like that, or an honeycomb looks like that. That's why, same, it's microscopy extrapolated. You have the perfect diagnosis, right? Great. Okay. Now let's go to few colors. Same in COVID-19, because COVID also undoubtedly will end up an interstitial lung disease or an interstitial fibrosis on the long run. Fine. So here, all these can be brown in color. Let's see how first we can differentiate them. That's a first step here. Once we know how to differentiate them, we have to know how to clinically correlate them to come to a diagnosis, right? I'm sure you guys will tell how to differentiate. What's the stain for melanin? Fastest finger first. The stain for melanin. Melanin is positive for Masson-Fontana, right? Perfect. So it's same special stain, Masson-Fontana positive. Great. What's the stain for copper? Though there are many stains for copper, I'm going to use a stain which I personally like it. It's Orcine stain, but rhodamine, your rubionic acid, any stain is right. But Orcine is also a stain for copper, right? Perfect. Lipofuscin, I generally don't have a stain. Lipofuscin is the location. When you have a brown color pigment, which is paranuclear in location on either sides of the nuclei, that's one first clue. Second, an elderly person without any symptom, because lipofuscin is a wear and tear pigment, right? So paranuclear location, think of lipofuscin. There is a stain for lipofuscin also, but I don't want you to remember that, right? Because it's not pathogenesis, right? What's the stain for hemosiderin? Perfect, right? Like Shruti said, hemosiderin has to be Pearl's Prussian blue. Just one more leading question, then we will apply all these facts into clinical scenarios. Hemosiderin or Pearl's Prussian blue, is it positive only for hemosiderin or both ferritin and hemosiderin? Pearl's is positive for hemosiderin only or both ferritin and hemosiderin? This has not been asked previously, but it's a very good source. If I was an examiner, I'd definitely put this. It is negative for ferritin, right? It's not positive for both. It's negative for ferritin. It's positive only for hemosiderin, right? Please do remember this, because I don't require ferritin, right? Ferritin is physiological form. So why do I need to identify physiological iron deposit? And it's seen only in duodenum. It doesn't matter for me at all, right? Where it's absorbed, it gets stored, that's all, right? So it's positive only in hemosiderin. It's positive only in pathological iron deposit, none of the physiological iron stores, right? Please do remember this, fine? The reason is actually the molecular formula. We'll not go into the depths of it, okay? Now, let's apply these facts and connect the dots, and I want you guys to write the whole person, elevated lesion in the tip of the finger, pleomorphic cells, brown pigments which are Masson-Fontana. Possibilities. It's melanin, obviously. Masson-Fontana positive has to be melanin. So tell me a diagnosis. Okay, there are multiple things. It could be a melanoma. It could be a nevus, right? It could be a freckle. Freckle also will have the freckle, lentigo will also have the black pigments, right? Why it is melanoma? When you say it's melanoma, why it is melanoma? You're right, it's malignant melanoma. The reason for me to call it melanoma is the pleomorphic cell. So it's not only the microscopic color. In addition to that, I have finding pleomorphism seen in malignancy, right? So since it's pleomorphic cell, I think of a melanoma. If the question didn't have this pleomorphic cell, I would want you to think of NEEP, right? Because NEEP is the benign tumor of melanocytes. It also can be a elevated lesion. It's nothing but a mole, right? If it's a completely flat lesion, it's not elevated, it's not a bump, freckle or lentigo, right? For all of them will be Mason's Fontana positive because all of them are pigmented lesions. If let's say, if I'm going to change this symptom, change the history, 28-year-old pregnant woman, there's discoloration in the cheek area. Skin biopsy shows melanin accumulation and Mason Fontana positive. Diagnosis? It's simple, right? You think of an melasma, right? So ideally, the only thing which alters in every damn question is the clinical scenario. If you're strong with your patients, entrance exam is a piece of cake. Because facts, fortunately, you guys are masters of facts. If you know the facts, the only thing is you need to be mentally present there and write the exam. That's more than enough, right? Melasma is a common finding seen in pregnancy and is a discoloration, Samantha. Fine. Okay. Perfect. That's the only thing required. And tell me, just off topic, what do you think is the most important thing for you to think properly in an exam? Can I say you need a very stable mind? That's the most important. If you're confused in the head, or if you're tired, if you're sleepy, do you think you'll be able to think properly? You can't. If you're hungry, do you think you'll be able to think properly? You can't. If you're stressed out, do you think you'll be able to think properly? You can't. So these are the three villains. It's not the knowledge. Knowledge is not a villain in a competitive exam, right? So please make sure. Unfortunately, my NEET PG said there are 2 sessions. I don't know which session you'll be writing. I hope NEET PG gives the NBMES gives a little bit of more clarity. But make sure your routine is changed from today onwards, not late. Okay, not late, but today onwards start changing it. Make sure you sleep around 10 o'clock, 11 o'clock. Wake up at 6 o'clock. That's fine. Then everyday morning breakfast is must. If you put on weight, it's fine for 1 month. After 1 month, you'll automatically reduce weight once you become JR. Don't worry about putting on weight. JR will suck the fat outside. It's the best liposuction available, right? So stabilize your routine. Automatically, everything else will fall in place, right? Yes, guy, melasma, chlasma, whatever it is. I'll leave it to the dermatologist for the terminologies. But the ultimate conveying point is pigmentation in pregnancy. You should be able to find it out. That's all. Okay. Okay. Next. Possibilities. Answer. 54-year-old congestive cardiac failure. On autopsy of the lungs, the biopsy shows a brown pigment which is Pearl's Prussian blue positive. Can anyone tell me the name of the cell? Can anyone tell me the name of the cell? Shubham. Okay, Shubham has gone with hemosidrosis. Okay, anyone else? Hemosidrosis. Anyone else? See, you are right bang on with this clue. That is perfectly right, right? Again, what you have missed here is, it's about connecting the dots. The patient presents congestive cardiac failure and it's a lung biopsy. I'm sure you must have heard about hemosidrosis, right? Hemosidrosis commonly involves liver, pancreas, skin, or it will involve lung. Will it involve lung or liver, pancreas, and skin? It will involve liver, pancreas, skin, pituitary, right? Lung involvement in hemosidrosis is very, very unlikely, right? Perfect. Now, when Dr. Sunny said left heart failure macrophage, it's nothing but an heart failure cells, that's all, right? This is what happens in an exam. I have a point which is correct and your brain says, okay, I know this, and option A will be hemosidrosis. You won't even think, you will jump to hemosidrosis, right? But hemosidrosis will not present like this. Hemosidrosis by default presents as an liver failure, bronze diabetes. I'm sure you must have heard about that, right? Pancreatic failure, skin pigmentation. Then yes, I think of an hemosidrosis. Look at the history, look at the finding, and come to the diagnosis, right? Clear. Great. Next. What's a diagnosis comes to your mind? Let's see how many of you can pick this up. I've hidden a very important clue for you here, but let's see if you can pick it up. Actually, history here is not supportive. Congestive cardiac failure, autopsy of the lung showed an elongated thread-like structure, which are Pearl's Prussian blue positive. Again, saying it is an iron-containing pigment. And this is the pigment. Clue is this. The patient was working in a ship industry. And obviously, you know, it's asbestos, right? This is asbestos. This is an indirect thing. This is the most important clue. I didn't give that clue because I want you to envision how an asbestos body looks like. This is a classical asbestos body which has been asked previously in exam. Obviously, an asbestos body or an ferruginous body has to be positive. The long-standing controversy which hardly comes in exam, which is the most common carcinoma in asbestosis, it's lung adenocarcinoma. Perfect. The most specific carcinoma is undoubtedly mesothelioma, right? Perfect, Divya. Amphiboal fibers are more pathogenic compared to your serpentine fibers, right? Great. Okay, next question. Okay, 54-year-old person, abdomen swelling, diagnosed to have cirrhosis, liver failure. Liver biopsy shows brown color pigment, which is positive for perspiration blue. Diagnosis? Now tell me the right diagnosis. Most of you guys told this answer in a different place. Now this is what is hemocirrhosis, right? Hemocirrhosis most often involves the liver, pancreas, skin, right? Don't forget them. Okay. Now I have two options. If both the options are there, now tell me which will be better. Hemochromatosis, hemocirrhosis, which will be better? For this case, which will be better? If both options are there, that's the trickiest part, right? Okay, what's the difference here? Of these two, which you think is congenital? Hemochromatosis congenital or hemocirrhosis congenital? Hemochromatosis congenital, right? It's inherited. Rather than saying congenital, I use the term inherited, right? So for hemocirrhosis to happen, by default, you should have a history of secondary iron overload. Hemocirrhosis and secondary iron overload. Secondary iron overload in the sense, I need to have at least a history of a repeated blood transfusion, right? You should have them, right? You should have repeated blood transfusion. So if I don't have any predisposing history, you go for hemochromatosis. In this condition, I don't have any predisposing history. In other words, it's a 20-year-old person, thalassaemic patient, repeated blood transfusion, and then you have liver failure, you think of an hemocirrhosis, right? So only when there's a secondary liver failure, I think of an hemocirrhosis, or iron overload, I think of hemocirrhosis. Otherwise, it's hemochromatosis only. Perfect. Okay. Secondary iron overload means it's that is secondary. Okay. Secondary iron overload means repeated blood transfusion. There's more iron deposit in the patient. That's what secondary iron overload means, right? Okay. Next. It's a simple one. 54-year-old, same history, abdomen swelling, diagnosed to have cirrhosis with liver failure. Liver biopsy shows brown color pigment, but they are positive for orcine. Diagnosis? I didn't change anything. I just changed one. The entire diagnosis changes. That's your classical Wilson's disease, right? Wilson's disease is how this is a classical presentation of Wilson's disease. They are orcine positive, which is copper positive by default. Fine, perfect. Okay. Orcine is positive for copper pigmentation. It's positive in Wilson's, right? So Wilson's, what is the classical presentation of Wilson's? Age. Will it present at 54 or will it present early onset? Wilson's. Wilson's presents a little bit early onset, right? It's present during adolescent age group. Wilson's classically present with tremors. KF ring, right? It will present early onset. KF ring, classical finding. Tremor is the most common, the CNS related, because it's your hepatolenticular degeneration, and also you'll have liver failure, right? Perfect. Can anyone tell me, you guys only said Wilson will have early presentation, and this I told the previous one, I'm thinking of an hemochromatosis, which will have a late presentation, right? Why? Hemochromatosis is also inherited. Wilson is also inherited. But why Wilson has an early presentation? Hemochromatosis has a late presentation. No. Not that, Sunny. Ion accumulation take time. No. It's simple. See, answer will be there if I know the basics. Wilson's is autosomal recessive inheritance. Okay. Hemochromatosis is also autosomal recessive inheritance. Fine. So, but hemochromatosis has something called a compound heterozygous state. Okay. So, it's because of the compound heterozygous state, and perfect. Like Nimra said, there's a brain involvement where brain cells, once it's damaged, will it come back to normal? Can I reproduce brain cells? I won't be able to reproduce brain cells, right? That's a reason Wilson's disease presents a little bit earlier compared to hemochromatosis, which primarily affects the liver. Liver can come back at a very fast pace, right? That's the reason Wilson's presents a little bit earlier compared to your hemochromatosis, right? Perfect. Okay, next question. 54-year-old, difficulty in swallowing, diagnosed to have an esophageal cancer. This came in an NEET PG exam. During surgery, a black nodule was found near hilum. Black pigments were seen in microscopy. Your diagnosis. Diagnosis? Normal? A carbon, right? Or an anthracotic pigment or a carbon. That's a thing, right? Yes, I can call it a normal also. It's melanoma or anthracosis is the doubt. Obviously, it has to be anthracosis because black pigments, melanoma will have melanin, which is brown color pigment, right? So if it's black color, there are only two possibilities. One is coal. There's one more place. A black color is seen in microscopy, but it's seen in liver biopsy. Can anyone tell what's a black color seen in liver biopsies? Pneumoconiosis or anthracosis. In liver biopsy, it is seen in patients with Dubin-Johnson syndrome, right? So these are the only two black color things which can be seen in the body. Microscopy, melanin is brown. Maybe to naked eye it can be black, but microscopy, undoubtedly melanin is brown. Dubin-Johnson in liver can have black deposit, and coal, anthracotic pigment in your hilar lymph node or in the lung can have a black color deposit, right? Yeah, epinephrine metabolites can have a black color deposit. Okay, great. Fine. If it's clear, what are the possibilities when it's clear? One thing we already know, if it's clear, I do think of fat, right? Yes, Shruti. Due to epinephrine and non-epinephrine metabolites, you have that. Do you know anything else which is clear apart from fat? So fat is clear. Fat containing cell, macrophage is clear. Mucin is clear. And if something is very thin, I will not be able to see them. That also is clear in microscope, right? Let's say I have a fiber, very thin fiber. I can't see them. It's clear in microscope, right? So how do I differentiate these things? Same, I have special stain. What's the stain for fat? Here, Sudan black and oil rido is a stain for fat, right? Same for macrophage as well, right? What's the stain for mucin? Can anyone tell me the stain for mucin? And Nimra already answered the question. In which section will it work? It will work only in case of your frozen section, right? Perfect. Alcian blue or an PS is positive in case of mucin based on the type of the nature of the mucin. Which of these two stains is positive in case of an acid mucin? Can anyone add on to it? Acid mucin, very specific question. Alcian blue is mostly positive in case of an acid mucin. PS can be for neutral as well as acidic mucin, fine. If something is very thin to see, I use an Warthin-Starry stain or a Steiner silver, basically silver stain. That's the reason why you use reticulin stain for your fibers, reticular fibers, right? We use Warthin-Starry or a Steiner silver for your Treponema pallidums and your H. pylori, right? That's the basic thing. If something is not able to see, I use special stain, right? So let's try to use these dots or the data into the form of clinical scenarios, fine? Okay, diagnosis. 47-year-old pancytopenia, bone marrow biopsy showed only clear spaces in the bone marrow. This is a very classical symptom. We did see one more case similarly, same age group, pancytopenia, bone marrow showed fibers which are collagen positive or Mason's sacrum positive. We had the diagnosis of myelofibrosis. Same history, microscopy changed, your diagnosis also changed, aplastic anemia, right? What happens to the bone marrow aspirate in aplastic anemia? You cannot forget that, right? Dry tap, right? A simple advice to all of you guys in future. How many of you want to do internal medicine here? Any of you medicine fans here? If yes, put up your hand or say yes. See, for everyone who's going to do internal medicine, you will be the first person who will be the point of contact for the patient, right? All the very best, Sunny, you will become, all of you who want to achieve, you will definitely do that, right? So the problem here is, you guys know by default it's a dry tap, right? Dry tap means I won't get anything. So tell me honestly, is bone marrow aspirate useful in case of an aplastic anemia? Yes or no? Not useful because I won't get anything. Is bone marrow aspirate useful in case of a myelofibrosis? No, right? I have learned something, so I have to use it. If I don't use it, it's waste. It's textbookish, right? So in future, if you suspect a person with an aplastic anemia, which can be clinically suspected with help of a microscopic peripheral smear and your examination, or a myelofibrosis, please don't do an aspirate. Straight away go to biopsy. Your knowledge should help the patient, not your NEET PG. That's a passing cloud, right? There's nothing there in the bone marrow, Samantha. It's empty. That's why it's a dry tap, fine? Okay, in fibrosis, it's caught up in fibers. That's why it's a dry tap, right? Perfect. Okay, next. Diagnosis. You guys will master. The only goal here is to learn how to connect the dots. If you can connect the dots, leave NEET PG. Everything else you'll be able to take care of it. Our goal is patience, not the exam. 45-year-old died of heart attack. Biopsy of LAD artery shows clear artery, foamy cells, and tunica edema. It's fat. Perfect. The answer is atherosclerosis. Definitely fat, but I have to give a perfect answer, right? It has to be an atherosclerosis or an atherosclerotic plaque, whatever is there, right? It's undoubtedly atherosclerosis, right? Next. Diagnosis. Let's see if anyone can pick up this answer. I'll give you one more clue here. 23-year-old, chronic diarrhea and anemia. Intestinal biopsy shows lots of clear vacuoles inside the epithelium, which are oil redopositive, which means this is nothing but fat, right? Perfect, Sunny, right? The clue was supposed to be this. This patient also had acanthocytes. Malabsorption is right, but the clue is acanthocytes. Now tell me, acanthocytes plus malabsorption, diagnosis? Like Sunny said, you think of an A beta lipoproteinemia, right? That's where you don't have fat absorption. Whipples will not have oil redopositive. Whipples will be PAS positive, diastase, PAS positive and diastase resistant, right? That's how Whipples will be. Since it's fat, you think of an A beta lipoproteinemia. Fine. Whoever answered Whipples might have the same symptom. In addition, Whipples can have few findings in the eye and the neurological symptom and joint pain, but it will be PAS positive and diastase resistant macrophages, right? Foamy macrophages. Perfect. Okay. Next question. Chronic diarrhea, intestinal biopsy shows lots of vacuoles in the epithelium, which are allicin blue positive. What is it? Let's see how many of you can get this right. Answer? Celiac, Whipples. Come on, everyone comment. Like it's completely fine. Let's see what's the answer. Because the answer is something very simple. It's just for a googly or a dusra here. I'm just keeping it so that I want you to think this also. That's a normal colonic mucin, right? Whichever Samantha said first, that's the right answer. Not always anything I see in microscopy should be a pathology, right? An epithelial mucin in an intestine is completely normal, right? That's how mucin will be. Goblet cells will be there in the vacuole in the epithelium. It's just a normal colonic mucin, that's all, right? It's just to make sure, not always think it's abnormal. Let's see, let's try and think sometimes it's normal as well, right? Okay, perfect. Next question. Answer? This I'm sure you will jump to the answer. Okay, 23-year-old heartburn, biopsy of the esophagus shows clear vacuoles. That's a classical diagnosis, right? You will not miss this. If you miss this, God will come and prick your eyes in the exam hall, right? It's Barrett's esophagus. Lower third of your esophagus will be involved. What is the cutoff point to differentiate them into short segment Barrett's and long segment Barrett's? Anyone? Short segment, long segment Barrett's. 3 centimeter, right? Less than 3 centimeter from J junction, we call it short segment. More than 3 centimeter from J junction, we call it long segment Barrett's esophagus. Fine. Okay. Barrett's esophagus will lead to squamous cell carcinoma or an adenocarcinoma. Great. Barrett's will lead to adenocarcinoma, right? Perfect. GRD and Barrett's esophagus. Fine. Lydia, that was an intestinal biopsy, right? Intestinal biopsy, goblet cells is normal, right? I didn't tell it's an esophageal biopsy. In esophageal biopsy, yes, goblet cells is abnormal. You think of an Barrett's esophagus, fine? Perfect. Okay, great. Next answer. It's a very simple thing. Chronic gastritis, biopsy taken, silver stain was done, revealed very thin black organisms in the lumen of glands. Diagnosis. It's a classical diagnosis. That's a silver stain, either a Warthin-Starry or your Steiner silver. That's a classical H. pylori, right? Tell me one most important non-invasive test done for detecting H. pylori infarction. Non-invasive. Carpal tunnel, I'll talk about giardia as well. Giardia will not be thin black organisms. I'm sure you must have seen giardia, right? Okay. Type B gastritis, right? Urease blood test is a non-invasive. It's very, very good. The best investigation is obviously to look at the organism like this. That's the undoubtedly gold standard, but urease blood test is very, very good. Fine. See, giardia will have this classical finding. It'll have this thing like a flagella. It looks like a ghost, right? I don't require a stain for giardia. And one more important clue, giardia will present malabsorption. What is the site of intestine where giardia is very common? Is it stomach, duodenum, jejunum, or ileum? the fallen leaf appearance, yes, right? It should always be in the duodenal biopsy, right? It'll be seen in the duodenal biopsy. That's the most important clue, right? Duodenal biopsy, you see something in the lumen, you call it a giardiasis, malabsorption, falling leaf motility, and looks like a amoeba, like an amoeba with flagella. You call it a giardiasis. Fine, perfect. Okay, next. There are two things which can be blue in color. One obviously is the nucleic acid, DNA, RNA, primarily nucleus, and another one is calcium, right? So calcium, I have two stains, but I want you to remember only one stain, which is 𝐼𝐶𝐄𝐝. The other one is alizarin, but fine. 𝐶𝐄𝐝 is more than enough for calcium. That will be more than enough for us to diagnose. This is the most commonly done stain as well. Fine. Okay, let's go to a question. Let's apply a few facts and come to conclusion. 55-year-old women, uterine lesion, biopsy was removed, and biopsy shows bluish deposit in the vessel wall, which is positive for 𝐼𝐶𝐄𝐝. What's your diagnosis? Again, a clue here. This is a normal finding. This has nothing to do with the uterine lesion. This is an old age finding. It's undoubtedly calcium. Calcium in the vessel wall. Diagnosis. Like I said, it's a normal finding. Fibrosis will not be positive for calcium, right, Shubham? Perfect, Nimra. It's your 𝐒𝐿-Burkitt's medial sclerosis or an 𝐒𝐿-Burkitt's arteriosclerosis, right? I'm sure you must have heard this. So here, this can be seen in any elderly person. So here, this is not the problem here. Problem is age. Anyone above 40 years will have this, fine? Next, atherosclerosis also will have calcification because atherosclerosis will have necrosis, right? But atherosclerosis, very, very unlikely to involve uterine vessels, first one. And atherosclerosis will be in the intima and not in the wall of the vessel. Fine, Sahil? Those are two differentiating points where I differentiates from 𝐒𝐿-Burkitt's from atherosclerosis. Like Nimra said, your vessel is not compromised here. Vessel wall is completely fine. Wall has blue deposit, that's all. If it's wall, not the intima, and it's not involving LAD artery or the prominent sites of atherosclerosis, think of 𝐒𝐿-Burkitt's. Okay? Next. Diagnosis. Same uterine lesion. Biopsy showed whorl deposits, positive for 𝐼𝐶𝐄𝐝. I have not changed the history. History is same. Maybe lesion also is possibly the same lesion. Now what's your diagnosis? The question is, what is the lesion here? The blue whorl deposits are your Samoma bodies. And Samoma body, like Deepak said, it is seen in uterine fibroid or leiomyoma. Fine. Samantha, atherosclerosis will be involving the major vessels. That's one clue. It will be in the intima, not in the vessel wall and the media. And you will have foam cells plus calcification. Okay, perfect. It's leiomyoma, right? Just one thing. Can anyone tell me one IHC marker used for leiomyoma? This has not been asked till now, I think, but I'm sure you guys know. There's a marker called as SMA, called as smooth muscle actin. Smooth muscle actin will seen in leiomyoma. Yes, Ishan, Samoma body entirely is nothing but calcification, right? Samantha, leiomyoma is a mesenchymal tumor. It will not be positive for cytokeratin, which is an epithelial marker. SMA stands for smooth muscle antigen, which is positive. MET12 is genetics, which can be positive in case of a leiomyoma. Fine. That's a mutation. Okay. Next. So let's look at few inflammatory cells. Fine. You have few inflammatory cells. These are the only inflammatory cells you want to remember. Neutrophils, how it looks in a biopsy, it look like a bent nuclei. That's all. Can you see the nuclei here? Tiny nuclei here. That's a bent nuclei. That's your neutrophil. If you look at eosinophil will have pink granules. I am not talking about nuclei here. It will be granular and pink in color. That's how an eosinophil looks like. Lymphocytes, undoubtedly small, round and blue. It's small, round and blue, that's all. Granuloma will have giant cells. That's how you pick up a granuloma. Those are giant cells in the granuloma, right? So these are four things at least I want you to remember here. Fine. Just remember this clue. That's more than enough. Bent nuclei for neutrophils, pink granules for eosinophils, small round blue cells for your lymphocytes, and giant cells is a clue to pick up granulomas, right? Okay. Macrophages will have clear cytoplasm, which we already saw, right? In case of foamy cell, it'll have clear cytoplasm by default. I'm not going with mast cells or basophils because they are very, very unlikely in pathological diseases, fine? And if any question says basophilia, what's the first diagnosis which comes to your mind? Everyone knows this answer. Where do you see basophilia? You see them in CML, right? So I don't require anything for further to diagnose. It's obviously seen in case of CML, right? Perfect. Okay. Now with that, I'm going to same four informations. Let's connect the dots and create beautiful scenario-based question and solve them. Fine. Perfect. Answer: 25-year-old colored urine, pedal edema, and proteinuria. Biopsy of the kidney is this. The clue is this. These are the cells here. These are cells here. Can I say these cells are neutrophils? Yes. Nephrotic and nephritic, colored urine. Colored urine is red color urine, right? That's neutrophil, PSGN. I think of an acute bacterial infection, think of an PSGN or a PIGN, whatever is there, go with the answer, right? That's how a classical microscopy of PSGN looks like. More number of cells inside the glomeruli, and these cells are generally your neutrophils, right? That's endocapillary proliferation, right? Perfect, great. Next. 45-year-old fever, breathlessness, consultation on X-ray, and this is the finding in the X-ray. Diagnosis. Can anyone tell me what are you seeing here? What are you seeing? This, when it's consultation and lung, it's your lung biopsy, obviously, right? So what are you seeing here? Can I say this is also neutrophil? Okay, will I call this granuloma? I won't call this granuloma, right? I don't see giant cells here. It's just pneumonia, that's all. All these are your septal capillaries, right? It's simple case of a pneumonia, right? I am not extrapolated much because here predominantly what you're seeing is neutrophils. Neutrophils, consolidation in X-ray, think of pneumonia by default. That's a classical word seen for most of them. I cannot call it lobar or anything because the microscopic finding, consolidation in X-ray, you think of a bacterial pneumonia most likely, fine? Okay, next. So now tell me, 45-year-old fever, breathlessness, again consolidation in X-ray. So I think of a pneumonia. But in this biopsy, if you look at this biopsy, it's very classical. This is an alveoli, this is an alveoli, this is an alveoli. Alveoli is clear here. So it's a typical pneumonia or an atypical pneumonia. You have a clear alveoli, and most of the cells in between the alveoli, what are they cells? They are neutrophils, lymphocytes, eosinophils, what are they? Atypical pneumonia, right? ARDS will have the pink color membrane. I don't have the pink color membrane, right? So I call this an interstitial pneumonia or an atypical pneumonia or a viral pneumonia. Most of the viral pneumonias will have interstitial infiltrates, will have lymphocytes, right? That's how your atypical pneumonia can be mycoplasma as well. It looks like that, right? I hope you are able to differentiate a viral pneumonia from a bacterial pneumonia. Bacterial pneumonia will have neutrophils, viral pneumonia obviously will have lymphocytes, right? Amazing, great. Diagnosis. I'll highlight the finding here. This is what I want you to look for. This is a cell which I want you to concentrate on. 23-year-old petechiae purpura biopsy, and this is a vessel biopsy. It's a blood vessel, perfect, Sunny. And you see a tiny cell in the corner. That's a cell which I want to concentrate on. I won't call it a tuberculosis. This is not a granuloma. Henoch purpura, it's not that. What's the cell which I have circled? Can anyone tell me the inflammatory cell there? We'll go to diagnosis later on. Can I say that's neutrophil? The one in the corner which I've highlighted? It's the bent nuclei, right? Perfect. It's neutrophil. Neutrophilic vasculitis. Have you heard about something called the sweet syndrome in dermatology? Yes. Acute neutrophilic dermatosis, right? Or a leukocytoclastic vasculitis. That's how neutrophilic vasculitis looks like. Sweet syndrome is how the biopsy of sweet syndrome looks like. Again, I want you to remember what is the microscopic inflammatory cell. That's all, right? There's a syndrome called sweet syndrome, which is neutrophilic dermatosis, skin lesion, petechiae purpura, microscopic vasculitis with involvement of the neutrophils. Fine, perfect. Okay, next. Same 23-year-old. I have not changed anything. I just changed the image. What inflammatory cell do you see here? Because the answer is based on that. What's the inflammatory cell seen here? It's a classical inflammatory cell. What inflammatory cell is that? Is it pink? Is it bent nuclei? Is it small round blue cells? It's eosinophil, right? Perfect. Your drug of choice, great. Now tell me, what disease comes to your mind when you think of vasculitis with eosinophilia? See, that's how you connect the dots. You already know that, right? Vasculitis with eosinophilia, what comes to your mind? Schuch-Strauss syndrome, right? Perfect. Drug-induced Schuch-Strauss syndrome, you think of that, right? It's vasculitis with eosinophilia, Montelukast related, classical case of Schuch-Strauss syndrome. Amazing, right? It's just connecting the dots. Make it very, very simple. More simple it is, more easy it is, right? Boil down to the easiest point, then build up your building. It'll be beautiful, right? Vaginous. Sahil has asked vaginous. Can anyone tell me what will be the microscopic feature in vaginous? Sahil, tell the entire name of vaginous. Vaginous granulomatosis, right? It's there in the name. So the microscopic finding in vaginous is multiple granulomas. So it's necrotizing granuloma, Sahil. That's what you see in vaginous. It will be there in the name, or it will be there in some part of the pathogenesis. Fine, perfect. Okay. Now tell me, what's the diagnosis? Can I put this as granuloma? Can I call this cell as giant cell? Yes, I can call this giant cell, right? 23-year-old petechiae purpura biopsy shows a granuloma giant cell. Can this be vaginous, Sahil? And everyone, this is how vaginous looks like. It's giant cell, right? Vasculitis, yes, TB, if there's an option, go with TB. But TB-induced vasculitis is a little bit unlikely. So granulomatous vasculitis we think of, right? Perfect. So now here, let me have the same image. I'm going to change the history. I want you to tell the answer. 60-year-old women having temporal headache, temporal artery biopsy shows this finding, diagnosis. That also allows the same finding. Your giant cell arteritis, that's all, right? Again, 35-year-old person having pain in the arm and has a very feeble radial pulse. Biopsy of the subclavian artery shows this diagnosis. Answer? Tachyas arteritis. See, that's all. So it's one microscopic finding. Vasculitis have 4 cells or 5 cells to remember. History is important. Correlation is important. You come to the answer. As simple as that. Everything will have the same finding, right? So that's more than enough for you to pick it up. Okay. And now, let's see. Pulseless syndrome or pulseless disease. 10-year-old kid, dysphagia, esophageal biopsy was done. And this is what is seen. What's your diagnosis? I'll give you a clue. This is a very unique gross finding also. It's an esophageal lesion, right? Gross finding has, esophageal is very simple. Can you add on to that your drug of choice? What esophagitis? What is the inflammatory cell here? It has a endoscopic finding which looks like a cat's tail. Perfect. Eosinophilic esophagitis or your feline esophagus, right? Perfect, right? So it strikes very hard when it's a PYQ, right? It has to strike hard for everything in medicine, right? It's simple terms. We can easily extrapolate eosinophilic esophagitis or a feline esophagus. Okay, perfect. Amazing. I want you guys to answer this. Just look at the inflammation. I'm 100% sure you can answer this question. It's an FNAC from a thyroid patient with 34-year-old hypothyroidism. And what are these cells? What are the inflammatory cells here? Is it bent nuclei, pink color, small round blue cells? What is the cell? That's a classical cell. Amazing. Hashimoto, right? The beauty of my pathology is it's not only pink and blue or only the microscopic slide. The beauty of pathology is the history and the correlation, right? It's lymphocytes, you think of Hashimoto. I'll have the same image. I am not changing the image. I'm just changing it to hyperthyroidism. What will be the answer? Hypothyroidism, you guys said Hashimoto. If the same image is there, but same age, but the patient has hyperthyroidism. Which is the autoimmune hyperthyroidism? Though I don't do biopsy for that or FNAC for that, Graves, that's all, right? So it's a clinical correlation which will make your life much easier. Connect the dots. Hypothyroidism, Hashimoto, hyperthyroidism, same image. I will think of a Graves disease. Though, like I said, I don't do an FNAC for that, but that should be the right answer, right? Perfect, amazing. Okay, let's see if we can pick this up. I'm sure you'll be able to pick it up. It's just the inflammatory cells. Here also what I'm seeing here is, these are inflammatory cells. What inflammatory cells are these? Clusters of small round blue cells, lymphocytes, right? Yes, Nimra, you'll see that. Amazing, Sunny. Parotid, dry eye, biopsy of the salivary gland shows this. That's classical, right? Which salivary gland biopsy is preferred in Sjogren's syndrome? Can anyone tell me? Is it parotid, submandibular? Which salivary gland biopsy is preferred in case of Sjogren's? It's your lip biopsy, right? Minor salivary glands are preferred for assessment. It's not the major salivary glands. You take a lip biopsy, the minor salivary glands, right? Perfect. Okay, great. Again, same here. This is what I want you to concentrate on. The inflammatory cells, same small round blue cells. Can anyone tell me the answer? 28-year-old, fatigue and weakness. I'll just give you a clue. The reason for fatigue here is anemia. Okay, anemia with lymphocytic infiltration, and one more clue, it's a macrocytic anemia. Can anyone come to an answer? Why celiac? Okay, I will rephrase this question. This is a gastric biopsy. Will celiac involve stomach? Celiac generally doesn't involve stomach, right? Let's assume this is a gastric biopsy. So in gastric biopsy, I am having a chronic gastritis and I am having fatigue and weakness. Couple of you told the right answer. Gastric biopsy, fatigue, weakness, macrocytic anemia. You think of an pernicious anemia, right? Okay. Now coming to celiac. Tell me what will be the presenting feature of celiac? Malabsorptive diarrhea or fatigue and weakness? Celiac presentation will be malabsorption and diarrhea. Fatigue will be there. It will cause nutritional deficiency, but the patient presents with diarrhea, right? History is very, very important. This patient presents with anemia. Then I have GA biopsy, gastric biopsy with macrocytic anemia. You think of a pernicious anemia, right? So history is very, very important. Based on that, correlate and diagnose them. Fine, perfect. Okay. Then few patterns. I'm going to tell you. Yes, Shubham, there can be multiple patterns. Celiac disease can present with neurological symptom also, right? But again, the common pattern. Common things are always common. Pernicious anemia presents with fatigue most of the time and gastritis. Celiac most of the time presents with your malabsorptive diarrhea. Fine. Okay. See, let's say membranous glomerulonephritis. Harrison clearly mentions that 15% of the patients are nephritic syndrome. But you don't read them, right? Our goal is the big one, big chunks. Okay. It's B12 deficiency. It is your pernicious anemia. Since the gastric biopsy and history of anemia, I go with pernicious anemia. Fine, sir? Okay. Few microscopic patterns, at least the important patterns which have been asked in the recent times. Keratin pulse, every squamous cell carcinoma. If you see a gland, you think of an adenocarcinoma. That's how you look for a gland. Okay. This is your nesting pattern. If you see nesting pattern, you think of carcinoid, seminomas, pheochromocytomas, paragangliomas, right? When I have tumor cells in the form of nest, in the form of enclosed area, I call it a nesting pattern, right? Small round blue cells, all blastemal tumors, embryonal tumors, Ewing sarcomas, right? I want you to restrict with these 4 patterns and let's kind of form MCQs around these 4 patterns, right? Nesting tumor pattern, squamous cell carcinoma, keratin pulse, glandular carcinoma, and small round blue cell pattern, right? Neuroendocrine tumors. Shruti, Zellbalan is also a variant of nesting pattern. Zellbalan means I think it's Greek language where it looks like a ball dance where they dance in circles. Zellbalan is primarily a nesting pattern. Fine. Okay. Now let's tell the option. What will be the answer? I'll give you 4 options. Tell me the most appropriate answer here. 10-year-old posterior fossa mass operated and slide shows small round blue cell tumor. This is the application of the pattern, right? It's medulloblastoma because posterior fossa, child, medulloblastoma. Can I say there's one more tumor in this which also involves a child and which also involves posterior fossa? What's the tumor? Which is the other tumor here which can involve the posterior fossa and can be seen in children? Pilocytic astrocytoma? Yes, perfect. What's the pattern for pilocytic astrocytoma? What do you see in microscopy? You see a fiber with R in the name. You think of Rosenthal fibers, right? If you see Rosenthal fibers, it's pilocytic astrocytoma. Small round blue cells, it's your medulloblastomas. Perfect. Okay. Next. 4 options. Tell me the most probable answer. "40-year-old lung mass operated slide shows nesting pattern diagnosis." Carcinoid, seminoma, pheochromocytoma, adenocarcinoma is not going to present that. It's classical carcinoid, right? So the pattern is useful along with the clinical history. Diagnosis. 1-year-old abdomen mass, operated slide shows small round blue cell tumor. Of this, both B and C can be small round blue cell. But B will not present as an abdomen mass. It will be present as an posterior fossa mass. Undoubtedly a neuroblastoma, which is an adrenal tumor. Adrenal gland tumor will be presenting as an abdomen mass only, right? Perfect. And age, 1-year-old is very, very important. Fine. Next, 40-year-old abdomen mass nesting pattern. See, what I'm doing here is I'm keeping the options same, but I'm just changing the history. When you change the history, the answer changes. Does not cross midline is a very important clue as well. Abdomen mass, nesting pattern, I go for pheochromocytoma because carcinoid can also have, but carcinoid generally does not present in the abdomen mass. It's pheochromocytoma predominant, right? Perfect, great. Okay, just few investigation of choice or the most likely next investigation to be done. Okay, if I have a known translocation, what's the investigation of choice? A known translocation since I'm seeing a patient with suspected Down syndrome. What is the best investigation of choice? If you have any known translocation, be it your BCR, ABL, be it your translocation 11, 14 in lymphomas, you do a FISH, which is better than karyotyping. If the translocation is known, FISH is better than karyotyping. When you have an unknown translocation, see, translocations will not be picked up on PCR coil, right? It's FISH. PCR is for mutations. Okay. When you have an unknown translocation, like in first trimester abortion, I don't know what's the problem, but I know it's genetic cause. What do? Perfect, you do karyotyping. That's for an abortus, you do a karyotyping, because for an unknown test, it's a sensitive test, right? Mutation, what's the first line? I have a point mutation. What's the first line of investigation? Point mutation, you do a PCR, right? You do a PCR. If I want to quantify, you do a qPCR or your real-time PCR, right? For every point mutation, you do only a PCR. Be it sickle cell anemia or any point mutation, you pick up a PCR. If the question is saying, what's the gold standard for a point mutation? PCR is undoubtedly good, but they are not gold standard, right? What's a gold standard for point mutation? Gold standard for point mutation is a test called sequencing. Sequencing is gold standard for point mutation, right? Sanger sequencing is great, or any sequencing is good, right? Carpal tunnel CRISPR is a gene therapy. It will not detect point mutation. It will help in treatment of the point mutations. Fine. Sanger sequencing or sequencing is good enough. Okay. Okay. Perfect. Now, hereditary spherocytosis. What's the best modality to diagnose? Tell me the investigation of choice. HS. It is flow cytometry. EMA flow cytometry or just flow cytometry is good enough. That's the best thing for diagnosing HS, right? Perfect. PS will tell me spherocytes your drug of choice, but it's not the best test or investigation of choice. That'll be the starting point. Obviously, fragility test will not be useful at all. That's one thing which I want to break the myth here. Osmotic fragility test is not useful at any point. It's flow cytometry, the investigation of choice. What's the investigation of choice for hemoglobinopathy? Like sickle, thalassemia, HBC. Perfect. It's HPLC. If it's there, good. If not, go for hemoglobin electrophoresis, right? Great. Okay. Test disease like G6PD deficiency. CGD stands for chronic granulomatous disease. What's the investigation of choice? For any enzyme deficiency throughout the body, the best test is assay the enzyme. If G6PD is less, it is G6PD deficiency. If your NADPH oxidase is less, it's NADPH oxidase deficiency. Right? It's enzyme analysis. That's the best investigation of choice for any enzyme deficiency. Fine. PNH, investigation of choice. What comes to your mind? PNH. Flow cytometry, right? If flare is there, it's a better thing, right? FLAER. Ignore the spelling error. It's FLAER. It's fluorescent aerolysine. Okay. Or a CD5559 flow cytometry is also is good enough, right? It's flare flow cytometry or a 5559, but ultimately it's flow cytometry for any of this is good enough, fine? Okay, next few more. CML, investigation of choice. CML. Flow or PCR? Or flow or FISH? It's FISH. FISH, than your karyotyping. Flow cytometry is not used here, right? Sahil, osmotic fragility is actually, honestly speaking, no use. None of the modern labs have osmotic fragility because we have come across. It's like Nokia phone. It's for legendary purpose. That's all. Fine. Okay. Acute leukemia, investigation of choice. Acute leuk, it's undoubtedly flow cytometry. Blood, if I can pick it up, or bone marrow. CD markers using flow cytometry, right? The purpose of flow cytometry is CD markers, fine? Okay. Lymphomas, investigation of choice. Can I pick up lymphomas on flow cytometry? It's difficult because flow needs a liquid, right? Lymphoma, the best is biopsy plus CD markers or your immunohistochemistry. That's the best thing, right? And what's the positive color in case of an IHC? Positive color is brown in color. And what's the reason for brown color? That was the last year question. IHC is immunohistochemistry. It's DAB. Diaminobenzene is the reason for brown color in case of a lymphoma, right? Perfect. CMPD stands for chronic myeloproliferative disorder. It's actually a criteria-based diagnosis. I don't have a single thing. It's a combination of genetics, bone marrow biopsy, and clinical scenario, right? For most of the CMPD, except for CMLs, fine? Okay, great. ITP, what's the best thing? ITP, textbook-wise, bone marrow biopsy is the best, but generally they don't do that. It's the clinical response. Patient with thrombocytopenia, they kind of do an give a steroid or a clinical response. That's the thing. You can definitely do a serology, but ITP is scenario and then a bone marrow biopsy, right? Platelet function defect. Mixing study comes in case of an isolated APTT prolongation of suspected hemophilia, right? For a platelet function defect, you do a platelet aggregometry, or I can do a flow cytometry here also to pick up where is a Bernard-Sollier or Glassman defect, right? Factor 13 deficiency. What's the first thing which comes to your mind? Factor 13 defect. What's the first thing which comes to your mind? We have something called a clot solubility test, right? So clot solubility test is the best investigation choice for factor 13 deficiency, or you have one more name for this called an urease lysis test, where also it can be used for factor 13 deficiency, right? What will be the classical symptom of a factor 13 deficiency? There's one classical symptom, delayed bleeding from umbilical cord stem, right? Delayed bleeding from umbilical cord stem is a classical finding seen in factor 13 deficiency, right? Okay. Now let's go to few keywords. I'll give you keywords or a clue, and I want you to tell me what's the first disease which comes to your mind, right? This is the last session. Maybe next 10 minutes we'll be done with, right? Fastest finger first. Very quickly, whatever comes to your mind first, okay? Young female malar discoid rash. We'll start with the easiest one. You can't forget this, right? Okay. Lydia, blotting techniques these days are literally not done. I'll leave it to the biochemist because more of an lab investigation which is there for historic importance, right? That's all. Okay. Young female salivary gland swelling. Great. Next question. Let's think of salivary gland. Salivary gland, lacrimal gland, young female. Think of Sjogren's syndrome by default, right? Female is a clue. Think of Sjogren's syndrome, fine. Smoker, male, bilateral parotid swelling. It's a tumor, that's a clue. What comes to your mind? Smoker, male, bilateral. Warthin's tumor, right? Smoker, male, bilateral. Undoubtedly, you think of a Warthin's tumor. That's the first thing which should come to your mind, right? A patient is admitted in the ward and there's bleeding from the IV line, bleeding from the gums, bleeding from everywhere. Diagnosis. The very classical clue here. Admitted patient, bleeding from everywhere. You think of DIC, right? If any patient in real life or question says bleeding from the IV line, you always think of a DIC. Admitted patient is where DIC is much more common, right? Perfect. What's the specific test for DIC? And what's a sensitive test for DIC? Specific is D dimer, sensitive is FDP, right? Perfect. Okay. Elderly patient, massive splenomegaly, leukocytosis. Diagnosis? Elderly patient, massive splenomegaly, leukocytosis. You think of an? Great, you think of an CML. Okay. Same history. I just changed the microscopic finding alone. Elderly patient, massive splenomegaly, but pancytopenia and monocytopenia. You think of? Hairy cell leukemia, right? The answer changes. You think of an hairy cell leukemia here, right? Next, 2-year-old patient with an prominent, you don't think of multiple myeloma, right? It's an hairy cell leukemia. Myeloma will not have hepatosplenomegaly, very, very unlikely. Myeloma will not have lymphadenopathy, fine. 2-year-old, prominent frontal bone, failure to thrive, microcytic anemia. Diagnosis? It's thalassemia. Most likely thalassemia major, because very early onset, right? Okay, next, classical symptom, 25-year-old, pain crisis, Patients having pain in the digits and priapism. Microscopy shows, I don't want a microscopy here. I want you to diagnose without microscopy. Think of a sickle cell anemia, right? Dactylitis, unexplained abdomen pain, recurrent abdomen pain, Afro-American or the commonest area in our country, you think of a sickle cell anemia, fine? Okay. Elderly patient, metallic heart valve. I want you to tell what will be the peripheral smear finding here. You have a classical finding in peripheral smear in case of metallic heart valve. Metallic heart valve, the RBC is go and hit, break, and we have cystiocytes or your helmet cell or your, it's a angiopathic hemolytic anemia, right? Perfect. Okay, next. Early morning first urine is hematuria and the patient has pancytopenia. Diagnosis. PNH, perfect, right? It's a PNH. And just one more leading question. What will be the bone marrow finding in PNH? Will it be an hyperplasia or a cellular marrow or an hypocellular marrow? In PNH. PNH will have cellular marrow because in hemolytic anemia, whenever there's a hemolytic anemia, the bone marrow proliferates and will have a cellular marrow, right? Pancytopenia with cellular marrow also, think of a PNH, right? Not hypo. Hypo will be seen in case of an aplastic anemia, right? Perfect. Okay. Gum hyperplasia with blasts in the peripheral smear. Gum hyperplasia with blast in the peripheral smear. This classical picture of a chloroma, I would think of an AML M4 and M5. M3 will have a different presentation. Most likely M4 or M5 would be the ideal presentation here. Or AML is good enough here, right? 6-year-old, what's a leukemia which comes to your mind? No other clue, just the age. 6-year-old, what leukemia comes to your mind? Okay, just think of an M4 or an M5. 6-year-old, what leukemia? You have to think of an ALL. By default, ALL, right? ALL is the common leukemia in children. 6-year-old, what lymphoma comes to your mind? There's only one non-Hodgkin's lymphoma which happens in children. A child, African child with a jaw swelling. That's a classical clue. It will be Burkitt. Rest, every lymphoma will happen in elderly, adults, or even adolescent. In a child, it should be Burkitt. In a child, leukemia has to be ALL by default. Fine. These are classical clues. Never miss them. Fine. A child, light tick lesion in the skull. Diagnosis. I should have stopped with that, but there's one more clue here. You have eosinophils and coffee bean nuclei. Even if the microscopy is not there, child, multiple light tick lesions in the skull. You think of an LCH. Langerhans and histiocytosis, you think of LCH, not multiple myeloma, because multiple myeloma does not happen in children, right? Children, light tick lesion skull, you think of an LCH. The same question is an elderly light tick lesion skull, you think of, now you are right, multiple myeloma, right? Keywords, age is very, very important because light tick lesion can be seen in two conditions, child as well as adults, different diagnosis, fine? Okay, perfect. Elderly, splenomegaly and gallstones. Elderly, splenomegaly, pigmented gallstones. This patient in microscopy will have spherocytosis. Okay. Could be possible, Lydia, based on other findings, other history. Is there an abdomen pain? Is there psychiatric depressants? Your parathyroidism can also be there, right? It's a hemolytic anemia, most likely HS. Classical presentation or triad of HS, elderly person, splenomegaly, and pigmented gallstones, right? Last question of today's lecture, and I want you guys to answer, everyone to answer here rightly. It's a very simple finding. There's an Ames PYQ, full house effect in case of an immunofluorescence in kidney. It's classical, right? We start with SLE and we'll end with the boss SLE, right? It's lupus nephritis, right? Perfect. So all the best. So we had, I think, a fruitful discussion for the past 1.5 hours. So hopefully I'll give this PPT. It's a PPT. It's not a PDF. I want you to want them to upload as a PPT. I'll tell them because before the day of the exam, just keep on swiping. We are used to swiping other social media. Let's swipe a PPT. Let's quickly revise so that it stays in your mind, right? And we'll have one-shot series for every subject in PWR. It'll be free for everyone. And we'll be starting around maybe in the middle of next week. And path will be on 29th of July. Hopefully we'll revise once more just before the exam. Fine. All the very best. See you soon. Bye bye. Thank you. Thank you guys. So any acute rejection, if it's a humoral rejection in kidney, it will be C4D positive. If that's your question, if it's humoral rejection, C4D will be positive. It will not be positive in case of cellular rejection. Okay. So all the best. Bye bye. Thank you.